Hi, everyone. My name is Natalie Yeadon. I'm the CEO and co-founder with Impetus Digital. At Impetus Digital, we have built some of the best-in-class asynchronous and synchronous virtual collaboration and communication tools. We have worked with pharmaceutical companies for the last 14 years to help them with everything from internal brand planning and strategy planning to virtual advisory boards to online medical education. But what's really important is that we actually work with pharma companies and having a series of these touch points with payers, physicians, allied healthcare providers, and even patients, working with them through a series of touch points to help them move strategies forward, plans, ideas, how to collaborate and work with people like we're going to be talking to today. So check it out if you're interested in looking at that. But more importantly at Impetus, we really believe that everything starts with a conversation. And from these big, hairy, audacious conversations with some of the leading edge thinkers, some of the digital provocateurs, and some of the healthcare thought leaders, we can all work together to collectively and positively disrupt healthcare. So I'm super thrilled to having one of these healthcare thought leaders at the table with me today. This is actually Anthony Capone. He's the president of DocGo. Here is where he's actually helped to build one of the largest providers of last mile mobile health services, as well as integrated medical transportation solutions in the United States. Anthony holds a graduate computer science degree in artificial intelligence from Clarkson University, as well as has over 20 years of software engineering experience. He has also led 3 companies from start to successful exit. In addition to his roles at DocGo, Anthony is a member of the Forbes Tech Council, and he writes on a variety of different topics at the intersection of healthcare and artificial intelligence. Welcome, Anthony. So happy to have you on the show today.
Thank you. Thank you, Natalie. It's a real pleasure.
Absolutely. I will say, having reviewed your background, it is super exciting. You've done a lot of things here, working on the computer science side of things, but then going on to the more entrepreneurial route and actually starting companies, selling them. So you have this really interesting experience. I was wondering if you could share with the audience a little bit about the career trajectory you have gone on and what brought you to DocGo.
Yeah, it's a lot. It's a lot. It's been quite the journey, and I am super, super lucky. In life, majority of the decisions which are most impactful to us, we don't actually make, who our parents are and where we're born and our genetic code, we don't choose those things. And so I was fortunate in that regard, maybe not all the genetics, but some of them. And so I started out really, really young. I was fortunate that my parents kind of really pushed me hard into computers. And so I started coding when I was 13. And, I had my first little startup company, Virtual Academics, when I was 15 and kind of sold that when I was my senior in high school. And from there, just continued to be fascinated with being able to take technology, specifically from a software perspective, and apply that to varying industries. I always kind of worked in a different industry, started out, in the educational software space for kind of classroom management, and then evolved from there into manufacturing software that was really more of like BIOS level machine type programming. And then from there evolving into tertiary education software. And then, I was fortunate to be part of Constant Contact, which is probably one of the nation's largest email marketing companies. And then the last company before going to DocGo is where I was running a kind of a quant fund out of Switzerland. I was really applying, AI and software to being able to make kind of algorithmic choices in the publicly traded markets. Nothing against the financial services industry, but I think I became a little bit burnt out at finding just a few more basis points in someone's portfolio, and really wanted to take all of those wonderful skills that were given to me, all of the history that had got me to that point of being able to provide value in a certain very, very niche area, and apply that to something that was perhaps a bit more beneficial to society. And that's where I kind of came in contact with Stan Wachowski, our CEO and founder. And we kind of linked up together in looked at this industry of healthcare, specifically originally was around emergency medical services in the ambulance industry, and saying, okay, how can we leverage technology to deliver both better patient outcomes, but actually, in an industry that usually the companies don't make any money, being able to make money so that we can then invest that into training, higher equipment, innovative ideas. And that's kind of where we built the company. Now, transport today is a smaller subset, but that's kind of how we built the company originally about 6.5 years ago, to where we are today.
Beautiful. So tell us a little bit about what DocGo is.
I love talking about DocGo. Few things get me going more. So DocGo today is probably the nation's, probably one of, if not the nation's largest fully mobile medical provider. Mobile medical meaning that we deliver care with an innovative model of both clinical care delivery and our model of being able to be on site. And when I say on site, I mean delivering care outside of the fixed four walls of a traditional healthcare institution. That could be in your home. That could be in a homeless shelter. That could be in an office for employer healthcare, or that could be in the back of one of our mobile urgent care buses. If you think about it, it's like a cutaway school bus that's been converted into a primary and urgent care clinic. It can be in any of those settings, but we deliver care in a innovative model that creates increased accessibility. And we believe that the key towards both reducing cost and ensuring compliance, so the urgent care side to try and keep people out of the emergency rooms, and the preventative primary care side to make sure that people are compliant with their treatment protocols relative to their chronic conditions. In both circumstances, the most critical element of success is accessibility. And so if we can go to them, wherever them is, it could be on the side of the street for a homeless, unsheltered homeless individual, it could be in someone's home, or it could be at someone's employer. But wherever it might be, wherever they need is where we go.
Wow, that sounds absolutely amazing. I want to kind of unpack some of this because there's a lot there. You said that this company was started 6.5 years ago. There was obviously a problem that you were trying to solve. Enter COVID-19, an entire pandemic that really turned the world upside down and made healthcare highly disruptible. Tell us a little bit about the trajectory or the course or any pivoting that DocGo had to do in order to meet the issues that started happening at the time of the pandemic.
Yeah, I'd like to think that DocGo is probably one of the most agile companies that are out there. We're here with a very strict mandate to provide value in the area of healthcare to society, and that's very broad. And so as we see opportunities where we can do that better, we move and we pivot. Right at the start of the pandemic, because elective procedures were being paused, suspended at various different health systems, our actual transport business started to decrease significantly because a lot of what we did was discharges from these hospitals, and they had low censuses, and it was more increase in some of our emergency business, but decrease in the non-emergency, which is a larger percentage. So faced with this kind of existential crisis of, are we going to shrink as a company and just accept the reality? We said, wait a second, we are in a healthcare pandemic, a crisis, and we have thousands of healthcare providers. Just because the single thing that they were initially trained to do for transport is not what is needed right this moment, for sure, something in healthcare is needed that they can do. And then that's where we started to really adapt and say, what more can our EMTs and our paramedics do? And then it continued to expand and expand. And that's when we formed our clinical practice group. Our clinical practice group is where we have all of our physicians, and we operate under a physician's license. We bring all of our providers under that license, our LPNs and our RNs and our PAs and our NPs. We started to build out that division because through the pandemic and now post-pandemic, there are two key differences that occurred, which have really driven DocGo's trajectory. The first one is, and I think everybody is well aware of this, is that society has become significantly more expectant of virtual healthcare solutions, and even solutions that don't make them leave their house, whether that is virtual or physical. So that's one cultural change that has happened in such a dramatic way. But virtual care only goes so far. If somebody calls you, if you go on a telehealth visit and you speak to your to a doctor and or a nurse, and they tell you, oh, well, you have high blood pressure, I want to titrate your meds, or I want to give you a prescription for high blood pressure. The standard protocol in most cases is that you need to then have you might need to have an EKG, blood pressure reading. You should probably have labs to determine whether or not, what your liver function is. Those are things that are standard. Well, if I already have to go in and go to a clinic, what was the purpose of trying to save time by doing the virtual visit? So virtual only goes so far. It can't really diagnose, can't do point of care testing. It's really just video and audio, and that's very limiting. DocGo has the virtual component, but then we bring people on site so that we have the physical touch point to be able to run those diagnostics, to be able to treat right then in there, whether that's a wound care, or delivering antibiotics, or whether that is doing something for people with chronic care management, like doing catheter flushes, or a long list of services that we do on site in that person's home. So that's one big fundamental change that's happened in society, is that people are more, their go-to, their default now is really, I want a telehealth solution, I want an in-person solution. The second big thing that changed really quick is on the government side. Municipalities, local municipalities didn't used to budget and have a significant area of responsibility for population health. It wasn't their responsibility. It wasn't a city or a town or a county's responsibility really for population health. That's changed dramatically. And so now when you look at budgets for a local municipality like New York City or LA or Chicago or Houston, like the percentage of their budget that's now being allocated and earmarked for healthcare, specifically population health of the underserved, has increased dramatically. And so those are the two areas that we operate in most predominantly. We deliver virtual on-site care for the underserved that's usually supported, or we are supporting a municipality in their population health efforts.
I see. So there's a specific niche that you're targeting. So if you're looking at the entire healthcare ecosystem, we realize that companies like Teladoc sort of took a very specific space in terms of the virtual healthcare system. They'll probably have a certain niche of people who can pay, et cetera. And then there's obviously people who've decided to come back to the institutional clinic environment to continue their healthcare. But you're talking about a very specific niche of the underserved, underprivileged population.
Yeah, I mean, but in the United States, that's more than half of the people. So it is a reality that I think sometimes as Americans, given, I think we have a little bit of pride in our culture, we don't like to accept, but the majority, not the minority, the majority of Americans are underserved when it comes to healthcare, when it comes to their healthcare needs. The majority have a chronic condition, at least one, whether that be diabetes or end-stage renal disease or chronic kidney disease, or they have COPD or CHF. This gambit, what you're talking about there, covers a very, very wide percentage. And then when you take that and then you include people who are on Medicaid or ACA or non-managed Medicare, or they're underinsured, so they're on like emergency Medicaid, these individuals, they get almost no access to primary and preventative care. No access to primary and preventative
So let's actually just walk that through as an individual or a consumer of your services. Let's just say, for example, I'm a woman who's staying in a women's shelter. I have, unmanaged diabetes as an example. How do I enter into the system? Who is referring me if I'm not actually accessing a primary physician? What is the patient journey?
Well, first and foremost, we start almost everything in our business by building a baseline. So when someone comes in, we initially do they go in through a check-in process. So if you're going into like a shelter, you're almost always going to have to go through a check-in vetting process that's usually organized by whoever's running that shelter. And through that, one of the first things that's required in most shelters, not all shelters, is that you undergo a health assessment. In varying different degrees, but we kind of follow this kind of HRA, health risk assessment model that's standardized by Medicare. And from that, we then build out and say, okay, this person has these either pre-existing conditions, or they have these chronic conditions that need treating, or they just simply haven't undergone any preventative care ever, and so we don't even know what it is that they may or may not be predisposed for, diseases that they currently have. And so we create that baseline from there. And then from that baseline, then we build out our kind of primary care type treatment protocols relative to what they are in need, which really falls under our care management division. Our care management division brings them in, and it's usually our clinicians. So they'll get on. And our model, our innovative kind of clinical delivery model, is that we're delivering care with a lower level provider on site. It could be like an LPN or an RN with an APP, which is like a PA or an NP, physician assistant, or a nurse practitioner, that is remotely supervising the entire clinical encounter. And that person who's remotely supervising can be a specialist. So if we get a patient who has some sort of cardiovascular issue, we can have a cardiologist or a cardiovascular nurse practitioner who is the one that's there, who's giving you very, very specifically specialized care guidance and directing that LPN. So that person, the women's shelter, they got their health risk assessment, and then from there we determined that they had diabetes. Now what we're doing in our care management program is that we're determining, okay, how do we get, first of all, remote patient monitoring set up so that we have the ability to know what your glucose levels are in various different times, usually every other day. And then from there, how are we set up so that we ensure that you're getting your medications? And so, we know that not only they're being prescribed, but we actually, in our pharmacy, we then dispense as well to make sure, because there's about 20 to 25% of patients who are prescribed medications don't get the first dose. So then how do we ensure that they actually get that first dose, because they might be new into diabetes or pre-diabetes. And so there's a lot of training involved there. And then ensuring that it's continuous, and then handling urgent episodic situations when, for instance, they might become hypoglycemic. And we have our team in the shelter who can deal with that rather than them having to go to the emergency room.
So tell us a little bit about the business model, Anthony. Who is technically paying for your process and system? And quite frankly, how is this different than, going through the Medicaid process and the caregivers and system that evolves from there?
Yeah, so majority of the time, in the case where we're dealing with the underserved, with population health, that tends to be contracted directly with one of the municipal organizations. So it could be contracting with whoever's in charge of that homeless, like the Department of Homeless Services, or it could be FSS, like the Family Services Department, or it could be the local county's hospital. Like in New York City, we have New York City Health and Hospitals, or it could be with the local Department of Health organization, which in New York City is Department of Health and Mental Hygiene, or it could be DMH, Department of Mental Health, in LA. But there's kind of 5 different agencies within a municipality who we may work with and contract directly with. Oftentimes it's not even DocGo's brand. So we usually appear oftentimes as the municipality, and we're following oftentimes the municipality's protocols, or we will create those protocols collaboratively, but we really want to work as an extension of the municipality from the perspective of delivering mobile healthcare or on-site healthcare in some of their most difficult to reach locations.
Got it. I see. Now, so there's a lot of interesting things, and one of the things that DocGo does is they've introduced and implemented technology into a system and a situation, an issue where it's becoming overwhelmed and overflooded, and basically in some ways kind of broken in a lot of ways. How is DocGo implementing and utilizing technology to optimize what's currently happening?
A lot of ways. First thing, it comes down to utilization. We built the company originally on utilization. The reason why most ambulance companies, when you get in, tend not to make any money is because of low utilization. So when you get in, you say, well, what can I do? Well, you can't pay people less because they're already usually making very close to minimum wage, a lot of companies. And you can't increase your revenue per transport because that's fixed by Medicare. So the only thing you can really do to make more money as an ambulance company is to do more. You run more trips on your shift. Well, we built out our own software. It's called Dara, which entirely focuses on utilization. It's routing optimization. It really leverages that AI. It was kind of the intellectual reason, I guess, that I joined the company, was that I had the ability to apply my academic training to a very practical circumstance of how do we have the ability to make sure the ambulances are running. Well, fast forward a few years to when we got into the mobile health division, that applies just the same way. How can we utilize our clinical resources in the most efficient way possible so that we can scale as quickly as possible, but also we can keep costs at a very, very low, at a very, very reasonable rate? Because keep in mind, oftentimes you might be dealing with like a Medicaid level reimbursement, which is very low. And the reason why Medicaid patients get such poor service is because the reimbursement rates are so low. So it's not worth it for most providers. You know, a doctor who might be making $250 an hour can't survive on a primary care visit with a Medicaid patient that pays, you know, maybe $50 or $60, right? It's just the unit economics don't work. We have a model where we use a lower level provider, and so our cost basis is much lower, combined with our technology, which is constantly making sure that we're utilizing those people in the maximum efficiency possible with very, very little idle time. So the tech, and we've probably put in just the first 2 years, probably $20 million worth of investment, probably over $45 million since inception of the company. You know, I'm at our headquarters right now in Herald Square, and we have a whole floor just dedicated to our whole software engineering team. You know, we're very big into having, you know, our New York-based software team here. And so the tech is the biggest differentiator when it comes to our ability to deliver innovative healthcare.
How else is the technology being used to manage the data, manage the people? We hear a lot about waste that happens in healthcare, especially with underserved and underprivileged populations who go in and out, who might abuse the system, who may be getting multiple prescriptions for things. How else is the technology helping to manage that and also to minimize costs for the payers?
Yeah, I mean, I think one of the key components that we believe in fundamentally is transparency. And so our technology basically feeds into these kind of BI dashboards, which gives our customers and our providers and our medical directors real-time transparency. Not like they have to ask for us, maybe the data is adulterated, you know, and we're just trying to skew it so that we look successful always. Real-time, objective, raw transparency. And that has been a critical, that's been probably one of the key reasons why we've been so high quality, is because whenever there's an issue, and trust me, there are issues, we are far from perfect as an organization, people know about them relatively quickly. And so then they get addressed, they get investigated, we do retrospectives, they get filed, we have a large compliance team and clinical team, which then does their kind of analysis and debrief to figure out, okay, what do we change going forward? But that real-time transparency, so the customer can come back to us by taking all that data in and saying, hey, you know, it looks like, you know, we had an issue at this site because you had a staffing issue, or because, you know, the efficiency at this site is too low, or, you know, all the issues when it comes to like complaints or encounters are in there, or just let's say customer service, simple, basic customer service. Every single patient that gets, every single patient that has a visit with us, they rate us with an NPS score. Every single one. So we have, you know, hundreds of thousands of NPS ratings. Because of that, we can go granular to where we know there's a low NPS site on a specific site or under a specific manager or with a specific provider, to that granularity. And then with that transparency goes back to the customer, and they could say, hey, this site, it has like a really low net promoter score for, you know, the patients that have been visiting there over the last month. What are we going to do? And they have that transparency, so they can also hold us accountable. And I think what that does is that builds a strong trust relationship with the customer, that we're not only telling them the good, but they can see for themselves the bad.
That's fantastic. We actually know, and this is across the globe, I mean, we've heard about the Great Resignation. We've heard about all these sorts of shortages, specifically in healthcare, because of burnout and because of COVID and all the the issues with that. I'm curious about the business model and the sustainability and the scalability, if you will, of a healthcare business that requires an actual feet on the ground services. What is the plan to continue to grow in light of basically a global healthcare worker shortage?
first, we acknowledged early on that this was the most important part of our business was people. Like, although the differentiator is technology, the core, the foundation is people. So we have to be very good at people. That means bringing in new people, retaining existing people, continuing to expand the scope of all of our existing people as well. And so I'd say we're best in class when it comes to staffing and when it comes to recruiting and keeping talent. That's for a multitude of reasons. But there are months where we'll go and we'll have to hire 500 providers in a month, 600 providers in a month, fully trained staff with all the logistics, all of our medical oversight, usually our equipment, our technology that they've been trained on, all of that together. And we will have a time frame where a normal company would have said, we need like 6 months, maybe 9 months. I got to build a project plan. I have to do, launch it very gradually. And DocGo comes in and, a municipality will come to us and say, I have this urgent, emergent need, and I need you to hire 600 people overnight, basically. And we get it done. We have a massive recruiting team, and we have a network of about 1 million providers that we pull from. And they're the ones that are able to come in and really fill that need very, very, very quickly. And so I think we, for us, and I would say that, DocGo is just in its first inning. I think we are right just at the start of what you're going to see of our company.
It's very exciting, actually, Anthony, because if we look back to the history of healthcare, there used to be house visits by physicians. That's kind of how it started. Yeah. Then we went back to institutional and clinic-based, and sort of we're now back at this place, but again, augmented and optimized with technology. There's a lot of discussion about, not enough healthcare spaces, the home becoming the new hospital. How do you see technology evolving and then utilizing people like at DocGo being able to service, if you will, people, within their homes? What is that going to look like in the future?
Well, I couldn't agree more with the sentiment that you started with there, which is that it used to be that healthcare was personalized with a physician that went into your home. It was taken out of the home and moved into large institutions like hospital systems, not because it was better clinically, but because it was more efficient. They're just simply, doctors ended up making more. There are fewer of them relative to the growing population. And so it just wasn't practical to have doctors going into the home relative to the cost. And so it was a cost reason, not a quality reason. So we, DocGo, I believe, have the ability to get back to that precise, concise, tailored model of healthcare to you that goes into your home or goes to your office or goes to your homeless shelter or your women's shelter or meets you on the curb, whatever it might be, where healthcare that's tailored to you without and solving the problem of that really extreme high cost when it comes to a doctor visiting you on site because of our clinical care delivery model. And so, when we look at we're actually kind of going back in time, if you will, to the way healthcare was originally developed, but now we're layering on this technology, which allows for not only all that real-time transparency and the routing and efficiency, but when our lower level clinician is physically on site, they have a large iPad Pro that's connected. That is connected then live with all of our remote diagnostic equipment that has high resolution medical grade cameras that are looking in your ears, looking in your throat, looking in your eyes, looking at your skin. They have with them all of the diagnostics for doing all of your EKG as an example. They can do point of care tests that get read back there. Like, let's say you call us and say, oh, my child has a throat irritation. We show up, the physician assistant tells our LPN, I need you to take the camera with the throat depressor or the tongue depressor and look down the back of the throat. Says, oh, there's some white specks. I'd like you to run a test. The LPN takes a throat culture, puts that into our Piccolo machine, and then very shortly thereafter is able to say, your child has strep. And then right after that, our physician assistant writes a script for antibiotics that goes to the pharmacy kiosk, little box that's in the back part of the SUV of the LPN. They walk out to their car, out pops the script for the antibiotics and maybe steroids, depending on how severe it is, right? And then they go back in the home and they give to the parent the antibiotics for your kid. So all in one place that we have the ability to do the diagnostic, the assessment, and the treatment all in one, maybe 30-minute span. And we're able to do that at a cost that is substantially lower than going to an emergency room and even lower than going to an urgent care. So convenience and cost are both better.
Well, Anthony, you just described a system that is actually way better than the healthcare system I currently have. Why can't I have access to on-demand diagnostics, assessment, and then medication dispensation? Why is this just going to be for the underserved and underprivileged?
It's not. If you're in New York or New Jersey today, you can go on to the iOS App Store. It'll soon be on Android as well. But right now you can go into the iOS App Store and you can download the app. It's called DocGo On Demand. And in that you can order exactly what I just described to you. You can wake up in the morning and say, my child isn't feeling good. I'd like a nurse to come and take a look at them. Select the time. Within an hour, maximum 2 hours, you're going to have a nurse at your house. It's in New York and New Jersey. And then as we're proving this out, we're going to expand it, and in Tennessee actually as well. And we're going to expand that across the entire country. We also have something similar like that up in Canada. We actually launched a B2C offering in Montreal. And so individuals can get similar services that I just mentioned up in Montreal, and eventually that'll expand to the rest of Canada.
Yeah, you will need to come to Toronto for sure. We're in a really big healthcare issue here, so we need doctors and we need healthcare. Anyway, that's absolutely fantastic. I'm just curious as well too, is there safety issues? You're going out into the wild, if you will. You don't really know what you're going to be getting into. How do you protect the subcontractors or employees of DocGo?
Yeah, and we have a lot of them. We're a big believer in employees, not really subcontractors or contractors. We have well over 4,000 of them, hitting the street every single day that we need to manage. A lot of it comes down to training, oftentimes having security guards on site as well. Many of the situations are precarious. A lot of the people that go and they work in the underserved, they do so because they want to make a difference and they know that there's a risk. There's a real risk associated with doing that. Sometimes, we encounter gang violence. Sometimes we encounter people that are highly mentally unstable, or they're addicted to drugs and they're going through withdrawal. All of those are very precarious situations that put our employees in difficult circumstances. So we have a lot of training protocols on how to detect that, how to de-escalate, how to have the security guards get involved, how to make sure that there's always multiple people in a room, just a lot of safeguards that really try to reduce and mitigate the chances that there's going to be a negative outcome when it comes to working with a patient or some sort of aggressive action. And we've learned a lot. I think over the last few years of doing this, we've gotten increasingly more proficient at ensuring that there's more and more safeguards to protect our employees. But I got to tell you, our employees who are out there every day, they do some of the greatest work in our country. I mean, they are truly delivering healthcare to people that don't have access to it, and they're not easy to work with. It's much easier to help somebody that wants to be helped and is easy and calm the whole time. Very difficult to help somebody who maybe isn't mentally cognitive and it doesn't have the capacity to understand that they need help, and is also very combative. Very difficult to help people like that. But
I got to tell you, it is very courageous work. Absolutely. And, power to it. I completely agree. And I think it's an extremely honorable business that you're running. So thank you for that. Curious about, you're an expert in artificial intelligence, all kinds of great technologies. What are you most excited about? What's next for DocGo?
Well, we're going to continue to grow, obviously, into more geographies and our existing service lines that we've proven out. So there's going to be a lot, that we'll see in our continued expansion. One of the things that, we're going to see more and more that we believe pretty strongly in is remote patient monitoring. And that is where, you have patients with chronic conditions and you can get kind of real-time data on them and their condition. We believe strongly that that does two things. One, that is the real-time data on their conditions that is more holistic, like you're looking at, not only what their blood pressure is, but what their sleep pattern is, not only what their glucose levels are, but also what their posterity and movement are for the day. And you look at that holistic view of a patient, that we believe that we can really dramatically reduce the likelihood of acute episodic circumstances where you have some sort of decompensation and the patient has to go to the emergency room, which is the most expensive part of care. So that's one angle on RPM, which I think is so interesting. The second is that it really is the catalyst to trigger all of our other services, whether that's the primary preventative services where we have to go and do more preventative care for that person because we just realized they're starting to progress into a disease, or on, all of our acute episodic services, as I mentioned, but all of our services across the board can really be utilized best when they are informed by data. And that RPM is what gives us the real-time data to be able to understand the patient, and then to use our AI to be able to do predictive analytics for trying to determine what patients have highest likelihoods of negative outcomes.
Fantastic. Wow. Phenomenal. I just absolutely love what you're doing. I'm very excited about it, and I'm wishing you the best. For anybody who's interested in connecting with Anthony Capone, learning more about DocGo, highly recommend look for his contact details in the show notes below. These are the kinds of things that we actually talk about in the Impetus Digital when we work with providers, patients, physicians, companies like DocGo, when we work together collaboratively, asynchronously and synchronously to devise plans to recreate customer journeys very similar to what DocGo has created. Is how do we scale this? How do we start talking? How does pharma get involved, especially with the idea of immediate dissemination of medication? So lots of cool things. Check out impetusdigital.com as well. We really appreciate, please like and subscribe to our channel. Really also, if you can leave us some feedback on iTunes, we really appreciate it. I want to thank everybody for their time today. And thank you, Anthony, for a phenomenal conversation.